Good morning, everybody. Good morning. We will get started. Thank you all for coming today. We have a great speaker for you today, Dr. Andrew Evans. But just to clarify any confusion, because I have been advertising Dr. Andrew Evans' visit lately, and someone sent me an email with a YouTube video of the famous stand-up comedian from Toronto, Andrew Evans. He said, "What business do you have inviting a comedian to our grand rally?" But I assure you, if you want the comedian, we will get him later on. But today, our guest is Dr. Andrew Evans from the University of Toronto. He received his undergraduate degree from the University of Western Ontario, from London, Ontario. He stayed there for his PhD. He came to us in Toronto for his medical degree, residency, and GU fellowship, pathology fellowship. So by training, he is a GU pathologist, but we will hear his story with digital pathology and telepathology. Today, Dr. Evans is a Canadian icon and certainly an international figure in the field of digital pathology. And we are so glad to have you here with us today, and we would like to hear your story. Please.
Thank you. Okay, good morning, everyone. It's a real pleasure to be here. I'd like to thank Mahmoud for inviting me to come. And actually, with regard to the stand-up comic crack, I guess you haven't heard my presentation yet, so it could be a bit of unintentional stand-up comedy. So what Mahmoud had asked me just to go through a very, I think, a timely topic for a lot of us in pathology, particularly those of us who work in centers with multiple sites where pathologists and slides and things are moving around for purposes of quality assurance and second opinion, etc. And so we thought to really try to drill down on the idea of barriers to adoption and what's being done, what the barriers are, and what's being done to address them. So I think the objectives for the next hour would be to cover digital pathology and telepathology and its value proposition, just some generic overview things, which I think are probably intuitive to most in the room. The evolution of telepathology at UHN and how we started using it, and how it's progressed through a series of niche applications, historical barriers to widespread adoption, and Mahmoud asked me particularly to talk about the issue of FDA clearance, how these adoption barriers have been addressed and are continuing to be addressed. By way of disclosure, I will mention two vendors that we've worked with at UHN in Toronto, Leica-Aperio. We have a long-standing vendor-client relationship and provide regular user feedback for product improvement. GE Omnics, I'm a member of their collaborators program, have been a paid consultant on clinical trial design for their FDA pre-market approval trial, and I serve as their principal investigator, but I have no shares in the company and no other interest to disclose. For definitions, I think telepathology and digital pathology tend to be used a little bit interchangeably, but telepathology, strictly speaking, refers to the transmission of pathology images and patient information for a variety of clinical applications. Whole slide imaging in particular, which is the focus of this presentation, recognizing there are a number of other modalities that can be used for telepathology. Whole slide imaging refers to high-resolution digitized replicas of glass slides created by a scanner. And in terms of the resolution, you're talking resolutions that are less than 0.5 micron per pixel, and then they're manipulated by software to simulate a microscope review experience in the form of a virtual slide. Now, in terms of the value proposition, I think for all of us, particularly in North America, there's a growing emphasis and a public expectation on improving quality in pathology. We talked a lot yesterday at lunch and during various other sessions about kind of the seemingly double standard between pathology and the rest of medicine. We're really held to a very high bar, and we seem to put ourselves up to this very high bar in terms of quality. And as I say, there's a growing expectation from the public to maintain or even improve on that. So telepathology using whole slide imaging or any other digital pathology modality for that matter will facilitates enhanced access to subspecialty expertise for consultation and quality assurance, allows the provision of pathology services to remote or underserviced regions, supporting solo pathologists, allowing workload leveling across sites when you have institutions with multiple partner sites. And in the province of Quebec, where they're along the north shore of the St. Lawrence River, where you have single pathologists that are separated from colleagues sometimes by 300 miles of distance. It's been difficult to recruit and retain pathologists there, and this has had an impact on recruiting and retaining surgeons. Because surgeons will say, if there isn't pathology support on site, then there's no place for me to operate there. So digital pathology has addressed a need there. A decreased need to transport glass slides, which over the long haul can reduce cost and importantly avoid lost or broken slides, which fortunately doesn't happen very often, but when it does, it can create a real problem. And improve turnaround time for consultations if you avoid the time associated with shipping slides. Now, importantly, I'll mention a little bit about this at the end of the talk, but I think the true potential for digital pathology lies in its facilitation of image analysis, which are things that a human being cannot do with a microscope. And then lastly, an issue, I'm not sure if it's come up here, but certainly in Toronto and other places in Canada, the issue of patient portals. So patients wanting access, online access to their complete medical record, including their pathology slides, which obviously digitized pathology record would enable. So I think Mahmoud has probably given you a pretty good overview of what UHN looks like and what we've done with the technology there, but I thought it would be helpful just to go through a few things. I think we have a pointer here. Yeah, right there. So the Consolidated Pathology Department sits here at Toronto General, and the digital pathology story really begins here at Toronto Western, which is 1 mile to the west of Toronto General. And we also have partner sites. So here's Toronto. We have partner sites in Sault Ste. Marie, in Timmins, Ontario. We do limited frozen section support for neuropathologists for neuropathology cases in Kingston, Ontario at Queen's University when their one neuropathologist is away. And then lastly, we have a primary diagnosis project at Lakeridge Health in Oshawa, which is about 40 miles to the east of Toronto. So I'll go through some of these in a little bit more detail. So we do function in a subspecialty model. As Mahmoud mentioned, my regular day job is genitourinary pathology. And in order to deliver subspecialty services across multiple sites, you're either moving slides, you're moving pathologists, or you can consider telepathology, which is what we did. And I'll try to take you through exactly how we've done it. The starting point, as I mentioned, was at the Toronto Western site. Going back, we knew by early 2006 we were slated for full departmental consolidation at the Toronto General site, not having any pathologists either at our Princess Margaret Cancer Centre site or at the Toronto Western site. Now, at Toronto Western, it created some immediate challenges for frozen sections. Most of the frozen sections come from neurosurgical procedures there. It's home to the Krembil Neurosciences program. It's not an enormous volume of frozen sections, anywhere from 2 to about 10 to 15 per week, but nonetheless, it would have caused or created the need for a single pathologist to run back and forth between Toronto General and Toronto Western. This is inefficient in terms of traveling and waiting. Things in the operating room change. You could get over there expecting a frozen section at 10 and it doesn't come until 11 in the morning. You can't leave. You get back to your office and your regular workflow is disrupted. You've missed sign out with residents. You've missed stat biopsies that people are looking for. And that's all to do about 15 minutes worth of work at the remote site. And then importantly, from a quality perspective, if there's a single pathologist there, there's no possibility for consultation on difficult cases. And I think every single pathologist in the room would tell you that we all like to have our hands held on difficult frozen sections. And then also, if you're going to defer a frozen section diagnosis to a surgeon, it just gives everyone that much more confidence if you can say, look, I reviewed it with this colleague or that colleague or 2 or 3 colleagues, and we can't come to a definitive diagnosis here, and this is what you have. Because I think most people would have had the experience, if you've been on call, where you defer a diagnosis to a surgeon, and the surgeon says, "Get me a pathologist who knows what it is." So, and nobody likes that. So, so with respect to whole slide imaging, we initially started in 2004 with a robotic microscope at the Toronto Western site, but then switched in October of '06 to an Aperio whole slide imaging platform. And since then, we've well over 4,000, actually pushing up close to 5,000 frozen sections, 90% from neurosurgery. In terms of discrepancy rates, 0 to 2% per year. I would say nobody has perfect concordance with frozen sections, and I'm always suspicious of anybody who tells me that they do. Most of them actually don't impact on patient care. It's usually tumor classification. In terms of turnaround time, we've been able to easily meet CAP accreditation benchmarks of having single block frozen sections turned around within 20 minutes. The deferral rate, the highest it's ever been in a single year was about 5%, and that just depends on the mix of cases that you get. Typically it's less than 1%. Where we do a complete deferral look, we really do not know what this is, and immunohistochemistry is required. And importantly, from a quality perspective, as I mentioned, it allows 2 pathologists to review all deferrals. Okay. And so why has this worked? I think, and this wasn't by design. This was purely just the way things unfolded. We had a single clearly defined need, and that's what we started with. So we were able to focus on one particular application, which was the neurosurgical frozen sections. It's a pretty uncomplicated workflow. The technologist there, and recognizing there is no pathologist or pathology resident on site, there's a technologist who's highly experienced at handling intraoperative neurosurgical material. They prepare squash preps, smears, frozen sections, and are highly skilled at doing so. They're not afraid of computers and have embraced the technology with the proper training. And so they can focus on one task at a time. I would never dream of trying to put this type of a workflow into our frozen section service at the Toronto General Hospital, where you could get 30 frozen sections in a morning. So it's much too complicated. Cases coming from multiple ORs at the same time, it does create a bit of a challenge. Not that it couldn't be done, but it would create a significant challenge. We also spent a long period in development with due diligence, which included, among other things, getting approval from our medical advisory committee internally, making sure that it would meet with approval of our medical malpractice insurance provider, the Canadian Medical Protective Association, and various other aspects of due diligence, and also validation. So we had done an upfront validation, and I'll have a little bit more to say about that a little later on. We had an implementation team that included histotechnologists, pathologists, IT people, the vendor, all the relevant stakeholders and people who would contribute to a successful implementation. And then finally, we developed a standard operating procedure, an SOP, which we rigorously adhere to. Now, people always will ask me this, so does it ever fail mid-case? And the answer is yes. So it's not 0, but to put it into perspective, it's 0.2% of cases. So we've had 10 episodes to date where a pathologist has had to call the surgeon and say something with the scanner, there's an unexpected problem with the scanner, and somebody has to either take the shuttle or get over to the Toronto Western site. So there'd be about a 10 to 15 minute delay in the turnaround time. And there have been some situations, we've learned from each one of them and have developed strategies to work around them so that they don't happen again. But there are some things that can happen, like a burned out scanner light bulb. There's no sort of light bulb life meter that tells you when the bulb is about to go. It just goes. And so some things can happen. And I think that the bottom line message is when you implement this, you have to be prepared to adapt and to adapt on the fly. Here's our plan B. The pathologist informs the surgeon and goes over. If we have a troubleshooting protocol, if things cannot be fixed within 5 minutes, then a pathologist calls the surgeon, goes over to the Toronto Western site, A second pathologist will actually stay with the histotechnologist and work just in case the case can be scanned and read, which has happened actually. And then if the pathologist, in order to get over there, we have a shuttle, we have a cab, we have bikes, and we also have this one. And this is probably, this, to be honest, is the fastest way to get there. I just thought I'd share a story. Here's my sort of one comedic venture, I think. When we first implemented the technology, all the surgeons at the Toronto Western, which was another important point of due diligence, we worked with them to tell them exactly how frozen sections would be done and how workflow would change and how we needed them to help us to help them. And so all the surgeons at the Western were familiar with how we were doing this. And occasionally there'll be some tag team procedures where there would be surgeons who don't normally operate at the Western that come over. And one such case here, this was a combined thoracics neurosurgical case. Just for argument's sake, or illustration's sake, the neurosurgeon was scrubbed in. The thoracic surgeon was off in the background waiting for his part of the case to come up. And the neurosurgeon had been sending a bunch of frozen sections, and I had reported 5 or 6 of them, and I was talking to the thoracic surgeon. And then I said, "Are you going to send any more?" And he said, "Well, probably 4 or 5 more." It was getting close to the end of the day. The technologist that was on duty for the day was due to finish at 5 p.m. And I said, "Well, the Toronto Western is on my way home, so I will come over to the Western," forgetting that this thoracic surgeon wouldn't know how I was doing the frozen sections. And he said, "What do you mean come over? Where are you?" And I said, "I'm in my office at Toronto General." And he said, "Well, how are you looking at these frozen sections?" And I said, "We're using it, using a robotic microscope by Telepathology." And then I heard him say this to his colleague. He said, "It's amazing, they're doing these frozen sections by telepathy." So we've since used the telepathy method for reading frozen sections at remote sites in Timmins. 1 week out of every month, there's no pathologist on site there. So we read frozen sections from Timmins, Ontario, which is about 420 miles north of Toronto. And likewise, I mentioned in Kingston, when their one neuropathologist is away, we provide backup coverage for pathologists who don't typically see those frozen sections. We've also used it for ultra-rush transplant biopsies. We have, again, a subspecialty type of service, so particularly liver and kidney. These biopsies can come at any hour of the day or night, and those pathologists, even when they've been in conferences, we've had people read ultra-rush biopsies from Italy, and then they can correspond with the transplant clinicians with whom they work on a daily basis, and deliver all of the highly nuanced reporting that most of us who don't read those biopsies on a regular basis or at all provide the experts' input that is really required. And then finally, we have a consultation project with a cancer hospital in Kuwait. It's not a super high volume of cases, about 50 to 60 cases per year. And it was a 5-year contract which has just come to an end, and it's being renegotiated now. But we've used Aperio scanners to provide help to those pathologists there. Now, the next thing I thought I would introduce was our primary diagnosis project. And just by definition, a primary diagnosis made by whole slide imaging would refer to one that is made purely on scan slides, and that's H&E, special stains, immunohistochemistry. The diagnostic information from this exercise becomes part of the patient record and is used for treatment decisions. And this takes us to our Lakeridge site, which we partnered with them actually in 2011, 2012 was actually when the primary diagnosis project got going after a long validation study that ran over a period of approximately 80 weeks. And there are pathologists on site there, but we switched them over to a subspecialty reporting model. So that left gaps in coverage in certain areas, which meant that certain types of specimens would be shipped in to Toronto with a daily courier run, in some cases twice daily. So we've used a phased implementation strategy for this, starting with people who were most experienced with digital pathology. And those also happen to coincide with the people that were the specialty areas that were not on site at the Lakeridge location. So that's genitourinary, endocrine, liver, and head and neck. And the idea is to attempt to scan all of these cases for groups. So the initial review is done digitally. But here's the important part. Pathologists can always request a glass slide when he or she thinks it's necessary to sign out a given case. So there's no pressure to, oh, you're only going to get digital, no more microscopes. That doesn't happen. So when they need a glass slide, they ask for it. And I'll show you the scenarios as to why people would defer. In terms of the cases from October 2012 to October of last year, we've done pretty close to 7,000 cases. That's 35,000 slides across those subspecialty areas. I should also note that Mahmoud had, before he left Toronto, had implemented a system with a pathologist at Sunnybrook Hospital who is very experienced in reading placental pathology. And this fellow, Chris Sherman, now actually does the reporting of placentas all digitally. Again, after a period of validation. So why do pathologists defer to glass slides? And this has happened in anywhere from 5 to 10% of cases over the last 3 years, and it varies with the pathologist who's on duty for a particular time and also the mix of cases. So the most common reason by far is if there's a difficult or an unusual case or an unexpected diagnosis where they're, in the estimation of the pathologist reviewing the case, there's a very high likelihood it would be sent out for review as glass slides by another pathologist. So something that might be contentious, everybody feels better if they've seen it both ways. And that would account for approximately 80% of the deferrals. Suboptimal IT performance, and I'll show you some examples of what we've encountered there. And this is particularly if a pathologist has a large volume of cases to report and they, just, this is slowing me down, I'm not going to continue using this. Performing diagnostic activities that are difficult to perform or currently not performed in a straightforward manner using whole slide imaging. And so counting mitoses per high power field, there are ways to do that. But some pathologists just feel more comfortable if they get the glass slide. They can ask for a specific one that they would want to count and then pop it on the microscope and away you go. Identifying microcalcifications in breast biopsies by polarized light microscopy, which our breast pathologists have identified as an important activity, but you can't do that on a whole slide image. And then finally, suboptimal image quality in an area of potential diagnostic importance. And this by far and away is it does happen, but it's the lowest on in terms of priority. So, if whole slide imaging is so great, why are more pathology groups not using it? So now we'll get into some of the barriers. The question I will often get is, does UHN still use microscopes? And the answer is yes. Like 20% of my service work is done by whole slide imaging, 80% is still done with glass slides and a microscope. And this kind of hybrid workflow, it does create some challenges again with implementation, and I'll describe those. And to put the use of the technology into perspective, whole slide imaging is used for clinical purposes on a regular basis by 40% of UHN pathologists. And then the rest of the people, they cover areas where there isn't a call for looking at digitized cases. And in some cases, there are some people in there who are quite fiercely resistant to the idea of learning it. They don't, take it away. I don't want to use this. So that should put into perspective the use of the technology. And I think in any department you would expect when you implement something new, any kind of a new technology, not just a pathologist, when it disrupts routine, you're going to expect people to dig in their heels and say, I'm not going to use this. And they usually have to discover some particular benefit to their practice before it pushes them over into adopting. So I think we are living the adoption challenges just like any other place. So in terms of the historical and current barriers to the adoption of digital pathology, this sort of David Letterman type top 6 list comes from a survey that we did. I'm part of a College of American Pathologists digital pathology committee, and we surveyed CAP members on a couple of occasions to look at their attitudes towards implementing this technology. And interestingly enough, the most recent survey, cost is the biggest barrier for pathology groups. So I'll go into some of that. IT-related challenges are a close second, and they're actually quite intimately tied into cost. Insufficient speed to support high-volume practice and a disruptive workflow, because it definitely changes how you approach your cases. Regulatory issues, the FDA. Pathologist resistance to change and perception of inferior performance. And then finally, lack of standards or best practice guidelines. We live in an era now where we have everything is driven by SOPs and checklists and standards and guidelines, etc. And until very recently, there weren't established guidelines, which has now changed. So in terms of cost, I think we looked just very briefly at direct cost and indirect cost. So the direct, buying all the scanner, the hardware, the software, the computing equipment. The indirect cost, you've got maintenance fees, just like any other piece of equipment, licensing fees for the software. If you're going to implement image analysis, that's a whole other issue. This is a big one, LIS integration, particularly if you're going to use it for primary diagnosis. I would say you really must have integrated whole slide imaging and LIS, because I think the possibility of having standalone and reading one prostate biopsy and reporting it in another patient's report is just too great. So I think you have to have everything tied together, and that brings with it a need for 2D barcoding and maybe retrofitting if you don't have that. And then there are also the IT costs. So there's the personnel, the operations, the storage, the archiving, and so on. IT-related challenges in particular, technical and connectivity. So I'll show you some examples of what the challenges that you can encounter there. APLIS integration, which I mentioned, storage and archiving, and then the personnel, and it definitely requires a team approach. I think when we first started with our frozen section implementation, we could not get an IT person from University Health Network to attend planning meetings. Initially, we were continually routed to a help desk. And then every time you call the help desk, you're speaking to somebody who's probably not on site. And you're going through this long diatribe of what you're trying to do and why you're using the technology. And the chances are every time you phone the help desk, you get a different person. So we really did push hard to get some stable input from our IT source, IT department. Connectivity and computing power. I mean, you definitely need sufficient RAM on workstations. You need to have a stable viewer and obviously suitable bandwidth between sites. And here's what can happen. You know, we have run into issues with our IT architecture, particularly if there's a lot of traffic on the network, and we've slowly tried to address these over the last few years. But you know, this is usually how it starts. You'll get some pixelation, and then eventually you just get this checkerboard where the viewer completely freezes and you can't diagnose anything. Now, this doesn't happen often, but again, if you're a bit of a naysayer to the use of the technology, all it has to do is it just has to happen once, and you'll say, "That's it, I'm done." So you have to be a bit patient. Storage and archiving, I think here you need robust, secure, and scalable systems, because depending on how you're using the technology, you can get up into terabytes, petabytes of data very quickly, depending on what you want to save. I mean, you do have to develop image retention and purging policies for diagnostic images, and I think it's really important to point out here that there is a potential gap, that there are no guidelines that suggest what you should retain or what you should delete. Nowhere. I've been involved with a number of different guidelines, College of American Pathologists, American Telemedicine Association, Canadian Association of Pathologists, and those various guidelines all say it's left to the discretion of the department program leader or administration as to what you retain. Also, you need consistently high performance in terms of connectivity for uploading and downloading, as I showed in the previous slide. The team approach, I think I've pretty much covered that. Who needs to be involved? Definitely a pathologist champion, which does require significant time investment, because you kind of have to sort of bear the pain of working things up and developing them before you roll them out to your colleagues. You don't want to roll out something that's half-baked, because people will lose their patience very quickly. Speed and workflow issues. So this is with the scanner and the capacity of the scanner, and this depends on how many slides you want to scan per unit of time, and this will actually largely guide what type of a scanner you buy, what capacity. So you wouldn't want to buy a scanner that holds 500 or 400 slides to read 2 or 3 frozen sections from a remote site per week. That's real overkill. But likewise, if you're scanning a few hundred slides a day, a 5-slide scanner is not going to work either. So I'll mention a bit about the hybrid workflow and finding digitized cases in the use of electronic work lists, which if you're not used to doing it is a significant culture change. Viewing speed for the pathologist. This is, anybody who's read anything about digital pathology will know that the usual refrain that you hear from colleagues, especially those who are new to digital pathology, is it's too slow. And we've gone through some of the issues, but one of the points that I would like to make is, pathologists being uncomfortable with the technology, it's often because they're not familiar with how to use the viewer to greatest advantage. So the default position is it can't be me, it's got to be the technology, but it's a little bit of both actually. And then input devices, which I'll mention here. So the usual input device that most people use is the mouse, and it can be problematic for large cases. And again, especially if you're not familiar with how to use the viewer, you can sort of get an aerobic workout dragging this mouse along your desk, and you don't necessarily have to do that. There are ways around it. But there are a variety of other input devices as well, including I got my middle son to configure a game controller, and I did try that. It worked reasonably well. Trackballs, 3D connection mice, touch pads, and then this was this one seems to be quite popular, at least amongst my colleagues. We don't have it in the department, but people who saw it at the recent USCAP meeting in Seattle were quite impressed with it. And it's much more like driving a slide with a microscope. This is for moving what you would do to move the stage, and then your controls for zooming in, zooming out, and advancing to a previous slide or going back, or advancing to the next slide or going back to a previous one. This group in Leeds, I think, they've done some really interesting work on, trying to drill down on the idea of the image, the technology being slower than reviewing glass slides with a microscope. And I think initially there were two things that came out of this particular study. One is that when a pathologist is turned loose on a digital image, they tend to be less organized with the approach. They're darting around all over the place. Whereas with a microscope, we have this routine where you'd go through in a very systematic fashion. In a very systematic way, you'd go through the slide. Whereas the digital, you kind of tend to be all over the place. There's this great big image in front of you, depending on the size of monitor that you have, and you can get distracted. And the other issue is that for the same case, this study showed that you make twice as many magnification changes, zoom in, zoom out type changes on a digital slide than you would with a light microscope. And then when these pathologists were asked why they were doing it, they said, I just want to make sure I'm not missing something. So there's this idea of learning to trust what you see at a lower resolution overview image and diving in. These are the types of things that you wouldn't do with a microscope because that trust is already there. So I think this explains in large part the learning curve and why in some cases, as this study showed, you could have up to twice the length of time to review the same slide, especially if you were relatively new to the technology. Now I'll talk a little bit about the hybrid workflow. So the idea of getting some of your cases as whole slide images and some of your cases as glass slides. And I think that the real point I wanted to make here is the culture change and learning to work with an electronic work list. And I've had some colleagues say, I'm too busy to check an electronic work list. I do work when people bring me glass slides and cardboard trays. And likewise, if you've ordered special stains in a case by whole slide imaging, again, your cue to do something is when that tray with the slide arrives in your inbox. And for a digital workflow, as I show in here, if you have this pile of slides, the question is, what's a pathologist going to report first? Everything can't be top priority, so you kind of have to triage what's in that list. Now, if you get a great big pile like this that comes for a group of pathologists, then naturally you're going to go for the work that you can see. You've got there, you can see it, you can touch it, you know it needs to be done. But the digital cases that are sitting in an electronic work list, you have to go and look for them. So I did have one, when we first implemented the Lakeridge project, I did have a colleague say, I haven't got any cases from Lakeridge. And I said, well, let's go look in your work list. And there were 10 cases sitting in there. So that's the kind of change. Now we are so used to knowing that we have work to do when you hear that clump of a bunch of trays in your inbox. This one, I think, I use this slide quite frequently. It was done by Curtis Stratman and colleagues who work at Omnix. And they spent time going to various pathology departments and watching pathologists sign out, just sitting like a fly on the wall during sign out with residents or when the pathologist was in his or her office by themselves. And you can see here they logged the amount of activity that went in to the various to sign out. And so we spend roughly 35% of our time reviewing slides, another 35% of our time putting things into an LIS, proofreading, checking, etc. There are other activities like looking up clinical information from the electronic patient record. And then there was this one, which these guys had kind of really dwelt on for a value proposition for digital, which is these workflow opportunities, which works out to about 45 minutes every day for a pathologist who's signing out full-time. Querying for previous cases, waiting for delivery of slides. If you get, you're waiting for a couple of slides to come, and then you get up from your chair, run down to the histology lab to look for a slide that might be missing. You're matching things up, you're matching requisitions, transporting various other materials, and all of this amounts to about 45 minutes a day. So they thought that if you had a complete digital workflow and you basically a case does not appear in your work list until it's ready, completely ready for you to review, that you could eliminate a lot of this material. And then looking at previous accessions, again, if you'd established a digital workflow, it was very easy to call up previous slides to look at biopsies to match with surgical specimens or serial biopsies, say in the case of liver pathology or transplant pathology, where you look for interval changes. But there are some other opportunities here, I think, going forward that really hinge on image analysis. And this one, I think Jeff Fine, a pathologist at UPMC, has written about this concept. And I've actually seen wireframe software that's in development to make this a reality. And this was this idea of pathologist computer-assisted diagnostics. So you could have an automated system where slides are already pre-annotated. So you come in the morning, slides are scanned overnight. There's annotation software that, analogous to a cytotechnologist putting dots on a pap smear slide, would alert the pathologist to particular areas, which would speed up your review of the slide. So you can go through and obviously accept or reject what's been annotated in terms of features of interest. And then the other one too was constructing a report as slides are reviewed. So if you're annotating things, if you're measuring things, etc., that as you're doing these activities, you can automatically populate synoptic fields in an LIS. So you can see that two pieces of that pie chart that I showed in the previous slide can be reduced. So you're spending you're reducing the amount of time in particular that you're spending on non-diagnostic work. So in terms of the use of whole slide imaging to date, most people have used computer screens the way we've used microscopes. So it's all been visual interpretation. Instead of looking down oculars, you're looking at a screen. And same thing for immunohistochemistry. You're either saying it's positive or negative, doing quantitative manual counting, semi-quantitative, 1 plus, 2 plus, 3 plus, but it's all visual. So there hasn't really been a big impetus on the use of image analysis. And I think that's where the real potential of this lies. Not so much, I mean, there is value, as I've said, to using it for visual interpretations, particularly when you have multiple sites and you'd be moving slides or moving pathologists. So there's value there. So I think image analysis, we're talking about software tools that will help pathologists and importantly not replace us. I don't think that will ever happen. But the intended goals are to allow a pathologist to act as a final interpreter of data that's been collected by software. So it's not just that a pathologist becomes a field selection technologist and the computer does everything, but we're actually the final interpreter of that information. And I think it does pave the way for more robust biomarker quantitation, which our oncology colleagues are asking for on a continual basis. Oncologists and patients like reports with hard numbers, which when we do things semi-quantitatively is not the case. Use cases that we've discussed, I think the low-hanging fruit here, and there are software algorithms already that will do this, so Ki67MIB1, other biomarker quantitation, ERPR, HER2/neu, those types of things are there. Mitotic figure counting, decision support tools for tumor grading, and a classic one would be architecture-based grading like Gleason grading in prostate cancer. And then automated case screening and quality assurance modules. And I think this, certainly in Ontario, there's a tremendous emphasis now on having second assurance or quality assurance, second overreads for new cancer diagnoses, and there really isn't any accounting for the extra workload on pathologists. It's just kind of expected that you will do this. And I think there is the possibility to, and I've seen prototype software that can actually facilitate this and ease some of that burden and actually do it in a very robust way. So in terms of KI67, I think we all know by visual inspection that it is time consuming, and I think it is also error prone, and there's data that shows that. And particularly for hotspot detection, there's data that shows pathologists are not particularly good at reliably picking out hotspots. And so I think the computers are very good at counting and quantitating things, and they don't get tired either. So they'll be able to continue on doing that. So now I'd like to move on to regulatory issues. We'll talk FDA, Health Canada, CE Mark. And I think it's important to note that all of these bodies, they regulate claims that vendors make about products. They don't regulate how pathologists can or cannot use these products, at least directly. Now, Health Canada had approved whole slide imaging platforms as Class 2 medical devices as of May 2013. So for us, this has not been an issue. The FDA, on the other hand, they practice regulatory science, and through my work with Omnix and their PMA trial, I've had several face-to-face meetings with the FDA, so I think I've come to have a reasonable understanding of the regulatory science pathway and what their job is. And they dwell very heavily on study design, spectrum of cases, readers, case enrichment, particularly for difficult, challenging diagnoses, pairing across modalities that are being compared, statistical robustness, numbers of cases, numbers of readers, and controlling for bias on all of these types of things. And if you want a really good idea as to how the FDA works, I think this particular paper, written by Brandon Gallis, who's a scientist at the FDA, describes their approach for imaging and computer-aided detection. And this is in diagnostic imaging, not in digital pathology, but it gives you a very solid overview of the FDA's approach to these technologies. And really, I think, to be absolutely fair to the FDA, they have an important job to do, and the idea is to balance timely access to new technology against providing or demonstrated safety for specific intended uses. And I think it's pretty difficult to argue that position. And they have the classification scheme. If you're not familiar with it, Class 1 is lowest risk, requires no pre-market notification, so that describes things like Band-Aids, microscopes with specific limitations. There are some aspects of microscopes that are FDA regulated from a manufacturing perspective. Class 2, moderate risk, that requires the 510K pathway, where there's a predicate device already on the market and it can be compared to the new device, and there are suitable controls and data on which to judge the performance of the new technology. And this is actually whole slide imaging for HER2, which has been approved. Is a Class 2. Now, interestingly enough, I thought robotic surgery systems, the Da Vinci robot, is a Class 2 medical device. And if any of you have seen what that could do, particularly in the hands of an inexperienced operator, one could do a lot of damage with that device. So I was quite surprised that it was there. Class 3 is deemed as the highest risk. It requires a pre-market approval study, and that's whole slide imaging for primary diagnosis off of H&E slides, although that is likely to change. And so the FDA had deemed that there were insufficient controls to evaluate safety. It was a great enough departure from the way pathologists have always worked that there was, in their view, the potential for unreasonable risk of injury or harm, and this required rigorous validation and manufacturing standards. So if you look at the timeline, the FDA really, this got onto their radar screen in 2009. There was a conference in Gaithersburg, Maryland, and I was invited to give an overview, a 5-minute snapshot summary of how we'd used the technology in Toronto to a panel that was gathering information from all various stakeholders. And then there were internal recommendations made by an advisory panel, but really nothing happened for 2 years. There were no public announcements of any decision or information. An FDA representative was invited to the Digital Pathology Association Visions meeting in San Diego in 2011. And there it was announced that whole slide imaging systems should be considered as Class 3 devices requiring a PMA. 2014, again, there was a period of silence for about 3 years. 2014, they released draft technical guidance for vendors for manufacturing standards on what would need to go into these systems. 2015, they finally released details for vendors on an acceptable pre-market approval study design. And this led very quickly to discussions with the Digital Pathology Association on how to go about down classifying whole slide imaging to class 2. And since then, there have been some very productive discussions, I think, between the two. And I think the first clearance is likely going to be expected in maybe the second quarter, but most likely the third quarter of 2017. You'll see the first clearance. So here's the, again, an excellent source to describe the regulatory barriers. It's written by a couple of friends of mine, Anil Parwani and Liren Pantanowitz, Louis Hassel, Eric Glassy, who chairs the CAP Digital Pathology Committee. That's Eric. So these guys in this particular review article, they spell out that the FDA doesn't have the authority to regulate laboratories or pathologists. We're functioning in the realm of CLIA and CAP accreditation. But what they do, they regulate whole slide imaging through the manufacturers and how the devices are labeled. So you can label them as in vitro diagnostic devices, which would be that's the labeling that you'd be seeking to use for diagnostic purposes, or research use only devices, which is what these whole slide imaging platforms are currently labeled as. Now, research only devices have long been introduced to patient care as validated LDTs following CLIA guidelines. And the FDA sought to block the LDT route for whole slide imaging in 2012, which by preventing vendors from knowingly selling RUO devices to those planning LDTs for diagnostic work. So that kind of put the brakes on the application of the technology. And then a couple of congressmen, along with vendors, tabled this resolution in Congress back in 2013. Called the Medical Testing Availability Act, and this was combined with public backlash, and then the FDA dropped this attempt to block the LDT route. And then following that, there was this very productive dialogue between the FDA and stakeholders, which I think has carried us to where we are now. So hopefully that gives you an idea as what the FDA's role is in all of this. And then they did release, this was a presentation given by Young-Fu Hu, a PhD scientist at the FDA, at a digital pathology meeting last summer in San Diego. So the clinical study design involves four different study sites, one scanner at each site, 4 reading pathologists at each site, so 16 in total, and they would be generalists and specialists as well. A total of 2,000 cases, so 500 cases at each site, read as both glass slides and as whole slide imaging with a suitable washout period. The data is collected, they're matched to discordance tables, and then the statisticians take things from there. So, and that's where things end. And the primary endpoint is demonstrating non-inferiority in diagnosis between whole slide imaging and glass slides. Now, the FDA has been very interested in the idea of identifying the risks of whole slide imaging, and if you look at the literature, the one issue that pops up consistently as an Achilles heel would be the identification of Helicobacter pylori on scan slides, particularly those scanned at 20x magnification, and particularly when the burden of organisms is small. And so, that, in my view, is not a reason to completely ban the technology, because you can't identify H. pylori on an H&E slide, because there are workarounds. You can use special stains, and importantly, you can defer to glass. I thought I'd just mention this. The College of Surgeons and Physicians of Ontario, which gives me my medical license, they had released a policy statement on telemedicine back in December of 2014, and it raises 2 interesting points. I think the first one is that telemedicine is medicine. So it's not like the B team of medical practice. It brings with it the same expectations in terms of deliverables and obligations. And then secondly, physicians must use their professional judgment on a case-by-case basis to determine whether they can discharge those responsibilities when using the technology. So I think the bottom line for us is, first, obviously we have to be aware of our professional obligations, and then If we can't deliver those obligations after looking at a digital slide, defer to a glass slide when it's necessary. And I think that's a safety valve that really has to be there. Now, sources of pathologist resistance for clinical use. This is actually a slide from Dr. Wally Henricks at Cleveland Clinic, and it was part of a digital pathology workshop that several of us did at the recent CAP meeting in Nashville. So there's fear, the fear of making a diagnostic error with it, working with a different workflow. There's loathing, being forced to use something that you're not comfortable with, and pressure. So initially taking more time to review a case per by whole slide imaging. So this fear, loathing, and pressure, adds up to resistance to adopting something new. And it wouldn't just be pathologists and whole slide imaging, but any kind of disruptive technology, this will happen. So, and then we come to the idea of the pathologist's perception of inferior performance. And you can get around that with validation study data. The literature is accruing multiple studies now that show that it's the performance for single institution experiences, the performance is not inferior to that of a light microscope, provided everybody's trained with the system, which is a huge, huge component, and also that you've optimized factors, particularly histology, the quality of the slides you put in the scanners. I think, in my experience, it is definitely a garbage in, garbage out phenomenon. If you put poor slides in the scanner, you get poor images out. And then this has been done in particular at the Cleveland Clinic, I think to great success for their international consultation program. They have a partnership with China, and they introduced the technology for what you would call low-stress activities, for tumor boards, for teaching, for collaborative research, and establishing departmental interesting case archives. And they've actually eliminated the glass slide recut from Cleveland Clinic. Now you get virtual recuts of slides, which has actually saved the lab a lot of money. And in terms of validation studies, what is learned by doing them? I think first and foremost that you establish for yourself that you can use whole slide imaging to make safe, accurate, and complete diagnoses. You also identify what needs to be optimized in terms of histology to facilitate digital sign-out. And probably the most important piece is that you'll unearth the limitations for your intended use or your practice setting. So cases that would require rescanning, cases that would require scanning at 40x or higher magnifications, and cases that would require deferral to glass slide review. And I think this is the biggest thing right here. And how often does that happen? These limitations would be about 5% of cases in our experience. So you're either, the glass is 95% full or it's 5% empty. And for people, and unfortunately I think people who would be naysayers to the technology will dwell on this 5%. In terms of validation studies, I mentioned there are a large number of them. These are just three recent ones, all following the CAP validation, whole slide imaging validation guideline. Now, in terms of guidelines, this will be the last part of the talk. There are now guidelines from the American Telemedicine Association, the Royal College of Pathologists in the UK, Canadian Association of Pathologists, the CAP whole slide imaging validation guideline, and then others in other countries that are a little bit older. But these three are the most recent ones. This is an overview of the topics covered in the American Telemedicine Association guideline. You can see it's very comprehensive, and it covers all of it's a kind of a nice checklist for those considering implementing the technology to make sure you have all the key bases covered off. And it's important to note about guidelines is that they will draw heavily, for any new technology, the guidelines will draw very heavily on the experience of early adopters, which doesn't mean that they're perfect, and they're far from perfect. But they will draw from the experience of early adopters, from the evidence of peer-reviewed literature where it exists, and unfortunately with a new technology, you do have to kind of resort to the opinion of early adopters. They are not standards of care, nor are they all-encompassing, but they're guidelines. They provide an important resource for new adopters for key issues to consider when you're implementing things. And what you will discover, I think, is that digital pathology is not a one-size-fits-all solution, that you will find particular things and nuances in your practice setting that may be very different than other ones that could actually prevent the implementation of the technology. But that's part of the validation process and planning and being prepared to implement it. But importantly, guidelines will be revised on a regular basis to account for advances in technology, for experience, importantly good and bad, from new adopters in diverse practice settings. And hopefully all of this will lead to the safe evolution of the technology. So in summary, I think we've tried to cover telepathology and its value proposition. I hope I've given you an understanding of how it evolved at UHN, the barriers to adoption and the role of the FDA in all of this, and then how these barriers have been addressed and continue to be addressed. And so I think my final two shots here would be that digital pathology, is ready for prime time so long as the users are ready for digital pathology. So you have to be prepared to implement it. And then finally, I think its true potential lies in image analysis. So this is just the beginning of it. And I just thought I would have to mention the support of IT people like terra-irists and histotechnologists, particularly this lady Suganthia Lalagan, who was really involved in getting the Toronto Western frozen section service going, and she is blessed with the ability to cut frozen sections that look like paraffin embedded sections, and has trained other histotechnologists to do the same. So she's shared her pearls of wisdom. My pathology colleagues actually, and Mahmoud, when he was there, was also involved in the validation studies, and then leadership. And I have to acknowledge the fact that the whole idea for implementing digital pathology came from Dr. Sylvia Eza. She had come back from a meeting in Europe in 2004, and recognizing we had these challenges at Toronto Western, asked for volunteers to lead a digital pathology implementation. Nobody put their hands up, self included, but she sought me out afterwards and asked me if I would do it. So I kind of fell into this role. It wasn't any sort of grand design. And then this fellow, Dr. Ranjan Chetty, he really rolled up his sleeves and helped with the early validation studies for the Toronto Western frozen section project. So with that, I think I've thrown a lot of information at you. I hope it's been useful, and I'm happy to take any questions. Yes?
I think one of the things that has struck me as we look at all this is what feels so far behind. Any of us who've done a conference with radiologists next to us feel small.
Yeah.
We feel really small. We watch them manipulate the whole body, go through everything, this and that. And then we get things like, hey, when you do a scan slide, can I go up and down and look for that nucleolus in the Reed-Sternberg cell? Hey, can I extract all the small lymphocytes and only find the big cells?
Yeah.
And I feel part of what's going on here is that the industry itself doesn't see the value, and the amount of capital being devoted to developing the software that drives all this isn't there. Yeah. And that leaves the rest of us who look at what we're going to get is kind of like, well, why don't I just put a slide under my microscope, take a picture of it with that, it's not much better. Yeah. It's not much better. So where do you see that this is going to get to a point where we will have those tools? I think,
absolutely,
honestly,
yes.
I don't think anybody wants to adopt this unless it's better.
Oh, I agree.
Slide.
I agree.
And it has to be easy to manipulate, and it has to allow me to do things like, hey, you know what, turn off all the small lymphocytes. Yeah. Do this, do that.
Yeah. I mean, as I said, the reason we implemented it was for a particular need to cover subspecialty pathology across multiple sites, and this was the way to do that. To really ramp things up for beyond niche applications to the wholesale applications that you just described, the software is absolutely coming. There are companies that do have, I've seen one, a virtual double stain algorithm that would do exactly what you described for lymphocytes. And you can actually tease out CD4, CD5, CD20 lymphocytes from the same slide. So you can just by doing, if several stains are done on serial sections, you can overlay those two and create masks, and then you can subtract different filters and see exactly where the various lymphocytes are. That's coming. You actually can buy one. The company is Visiopharm that markets that. In terms of Z-stacking and multiplanar focusing, that's something that vendors have heard for a long time that they need to address. There are hybrid devices now that will allow you to do that. It's not, in terms of efficiency, I think to your point, it's an excellent one. It's not this technology that I described, the real-time Z-stacking, isn't really ready for high throughput use, but for selected slides, it's definitely there. And I think it behooves all of us in the pathology community that want to use this technology to keep feeding back to the vendors. This is what we need. You know, they can't, I think the companies that are going to be most successful are the ones that actually get into pathology laboratories and really understand what the pain points are with the technology, and also just with regular workflow, even with glass slides, and how the technology can be developed to improve it. But if they sit and attend conferences and then take instruments that they've developed without the input of pathologists, it's not going to fly. So you raise an excellent point. Yes.
One quick comment.
Yes.
So I didn't train as a resident here, but where I trained, they had neurosurgeons at 2 sites, but neuropathologists at 1 site. So what we did is when we were on the site without neuropathologists, the residents made squash pads and frozens and put them on a remote viewing scope. That actually worked pretty well.
It does, yeah.
It was slower than looking at glass, but it saved the pathologist time having to drive out to the site and drive back. So it's useful in that scenario.
Yep.
But, I'm a hematopathologist, so I'm curious if you can provide comment on either cytology or bone marrow aspirates where you have to use 50 or 100x oil, and how the technology of your institution has been integrated to really look at.
Yeah, we haven't used it for that purpose. We did have, there was a pilot project in place where we had a scanner that had a 100x oil immersion lens that would allow for scanning of bone marrow aspirates and blood films for new leukemia diagnoses that the hematologists, the lab is at Toronto General and across the street at the Princess Margaret Cancer Center. The hematologists considered the review of the bone marrows and the aspirates and the biopsies and the blood films as kind of an extension of the physical exam. So they would like to review those things in consultation with a hematopathologist who was signing them out. And there was necessarily a lot of running back and forth across University Avenue to do that, either pathologists trundling slides across or the hemoncs coming across from Princess Margaret. And so we did run a pilot project with a 100x oil immersion scanner, which did work. I mean, those files are enormous. That's... It takes a long time to scan, exactly. I mean, the images are beautiful. You can see nucleoli that are the size of your head on a computer monitor. But and the group that I'm aware of that's done the most work with hemonc is at ARUP in Utah, Dr. Mohammed Salama. So if you look at some of his papers, they've implemented it successfully for tumor boards, for hematology, oncology tumor boards. And they have, I think, the greatest single institution experience with it for hematology applications. But again, it comes down to the same issue with for cytology and real-time Z-stacking, multiplanar focusing.
You have kind of a hybrid, so I think that the most automated hematology labs
Yeah.
incorporate television.
Yes.
So if you have an abnormal smear,
Yeah.
you scan it, but the computer only scans or incorporates the white cells.
It's flagging particular cells, yeah.
So I think that there was some resistance to it, but as soon as the lab staff started realizing that rather than have to screen a homemade peripheral smear, that you could have the computer scan it and then you could evaluate.
Yeah, at a couple of our Northern Ontario sites, there are television systems implemented there, where there's no on-site pathologist to screen those types of cases. And also, particularly another issue for our Northern Ontario sites is we had to have the ability, just through Ministry of Health regulations, you had to have the ability on site to assess for malaria, for parasites. So that was, and I actually don't know how well television would or wouldn't perform in that regard. But we did look at having an oil immersion scanner at our Timmins site to facilitate that. So there's no question there is more work that needs to be done to really ramp things up on the cytology side. And as I said, I think for those particular applications, these hybrid devices, like there's a Sakura Vision Tech scanner, I think it's called the M6, is the latest one, which functions as a real-time video microscope, also as a whole slide imaging scanner, and we'll also do multiplanar scanning to create Z-stacked whole slide images. So
we just ran out of time,
okay.
and Dr. Evans will be available thereafter. after for discussion after the residents' presentation.
So-
Thank you very much for the.
Thanks very much.